Ladies and gentlemen.
This episode is sponsored by Advanced Skills Company, the official agent of JPI Healthcare in Iraq. I personally use the products of JPI Healthcare in my clinic for years now, and throughout the years, these products have been amazing in terms of providing excellent image quality at the lowest radiation dose possible, and they are durable, reliable, and efficient. I recommend, if you are looking to establish your radiology practice, whether in a clinic, in a center, or in a hospital setting, to go to the JPI Healthcare website, see their products for yourself, and then call Advanced Skills Company if you are in Iraq, and these guys will provide the best possible solutions, whether in terms of hardware or software. I will leave the contact information in the video description, and don't forget to use the magic word highlights in radiology, because you will get a 10% discount on all JPI Healthcare products till the end of 2024. Hello everyone, and welcome to a new episode of Highlights in Radiology. Today we are going to talk about a very important topic, which is osteosarcoma. Before we start, I want to remind you to subscribe, like, share, and tell your friends about us. This is Dr. Ahmed Abdul Wahab, and this is Highlights in Radiology Season 2. Stay with me. Osteosarcoma is defined as a malignant tumor with the ability to produce osteoid directly from neoplastic cells. The majority of osteosarcomas are of unknown etiology, and they are called primary osteosarcomas. Also, it can be secondary to predisposing factors like Paget's disease, bone infarct, and radiation, and it's called secondary osteosarcomas. It is the most common malignant primary tumor in young adults and children, and it constitutes 20% of all primary bone malignancies. It has a bimodal distribution, with the first peak seen involving the second to third decade of life, while the second peak is seen in patients over their sixth decade of life. It's slightly more common in females than males and slightly more common in African Americans. The most common presentation is a progressive pain with soft tissue mass and swelling. Pathologic fractures and pulmonary metastases are common. These metastases can appear as calcified pulmonary lesions, and they can cause pneumothorax. There will be increased serum alkaline phosphatase. Keep in mind that patients with osteosarcoma are often taller than their peers. Osteosarcoma is a very aggressive tumor, and its prognosis depends on the grade of osteosarcoma, the size, the location, and the resectability, and the presence of metastasis. The central osteosarcoma has worse prognosis than juxta-articular type, with 5-year survival of 41%, while the 5-year survival in patients with resectable tumor and without metastasis is about 60 to 70%. Treatment includes surgical resection with wide margins and adjuvant and neoadjuvant chemotherapy. Amputation may be necessary, and biopsies must be planned with a future tumor excision in mind. So what radiology can offer to us in cases of osteosarcoma? Well, the most important radiologic feature is bone destruction with associated tumor bone formation and aggressive periosteal reaction. It is seen most commonly around the knee in 55% of cases, usually involving the metaphysis of long tubular bones in about 80% of cases. Extension to epiphysis is seen in 75% of cases. As in this example of femur osteosarcoma, we can see that it's close to the knee joint with aggressive pattern of periosteal reaction and a new bone formation. The flat bones and the vertebral bodies are involved in 20% of cases, while in older patients more than 50 years of age, the axial skeleton and flat bones are involved in about 40% of cases. Like in this case of vertebral osteosarcoma, we can see the destructive lesion with a new bone formation and sunburst periosteal reaction involving the vertebra and its arch. The tumor usually ranges in size from 5 to 10 centimeters. Regarding plain radiography, 85% of conventional osteosarcomas will appear as a poorly defined intramedullary mass extending through the cortex. It can show moth E10, bone destruction, and aggressive periosteal reaction like Codman triangle or sunburst pattern. There will be indistinct border with wide zone of transition and soft tissue mass with or without tumor calcification. Like in this case, we can see that there is a poorly defined intramedullary mass extending through the cortex with signs of bone destruction and aggressive periosteal reaction like Codman triangle and sunburst pattern. The borders are indistinct with wide zone of transition with the tumor calcification. Another example, in this case, we can see that there is a poorly defined intramedullary mass extending through the cortex with signs of bone destruction and aggressive periosteal reaction. Codman triangle is seen. The borders are indistinct with wide zone of transition with the tumor calcification. In telangiectatic osteosarcoma, which constitutes less than 5% of cases, it will appear as a purely lytic lesion with cystic cavities filled with blood necrosis fluid levels, and it can mimic aneurysmal bone cyst. Like in this example, we can see a lytic lesion with cystic cavities. It may mimic aneurysmal bone cyst. Multicentric osteosarcoma constitutes 1% of osteosarcomas, manifests as synchronous osteoblastic osteosarcomas at multiple sites, usually symmetric, and it is seen exclusively in children of 5 to 10 years of age with extremely poor prognosis. As in this case, we can notice that the growth plate is still open, suggesting a young patient. The lesion is involving the femur on one side and the tibia on the other side with sclerosis and ill-defined borders. Soft tissue mass with calcification is seen in the femur. Parosteal osteosarcoma constitutes 3% of cases. It's a low-grade osteosarcoma seen in older age group of about 20 to 50 years of age, usually involving the posterior distal femur, and it is attached to the underlying cortex at its origin. As in this example, we can see the tumor involving the posterior distal femur, and it is attached to the underlying cortex at the origin with calcification. Periosteal osteosarcoma constitutes 1% of cases. It is an intermediate grade osteosarcoma, and most commonly it is diaphyseal in location with cortical thickening and no medullary involvement. As in this case, we can see clearly the diaphyseal involvement with some cortical thickening and no obvious medullary involvement. Non-thick osteosarcoma constitutes 5 to 10% of cases, and it shows involvement of the mandible and maxilla. It can be sclerotic, lytic, or mixed with periosteal reaction and soft tissue extension. As in this example, we can see the involvement of the mandible with sclerotic lesion and periosteal reaction of sunburst pattern and a large soft tissue component. Secondary osteosarcoma constitutes 5% of cases, arise in association with a pre-existing condition of the bone such as Paget's disease, prior radiation, or bone infarct. As in this example, we can see features of Paget's disease with a left femoral sclerotic pattern. In this adult patient, we can see also sunburst pattern of periosteal reaction suggesting secondary osteosarcoma. Regarding CT scan, it is helpful in imaging the surface osteosarcomas. It can show complex anatomy in naphthik osteosarcoma, and after contrast injection, it will show enhancement of the soft tissue component, and it helps to differentiate the telangiectatic osteosarcoma from aneurysmal bone cyst, because in telangiectatic osteosarcoma there will be nodular peripheral enhancement. In this case, we can see nodular peripheral enhancement suggesting telangiectatic osteosarcoma rather than aneurysmal bone cyst. In MRI, on T1 weighted imaging, we will see low signal intensity in the mineralized tumor and low to intermediate signal intensity in the solid non-mineralized tumor. While in T2 weighted imaging, there will be low signal intensity in the mineralized tumor and high signal intensity in the non-mineralized tumor with soft tissue mass. STIR is helpful in imaging of the entire bone to detect skip lesions and in multicentric osteosarcomas. Like in this example, we can see the tumor having low signal intensity on T1 weighted image and high signal intensity on T2 weighted image, with areas of low signal intensity of T1 and T2 weighted images indicating areas of mineralized bone. Another example, we can see the tumor having high signal intensity on T2 weighted images with marked post-contrast enhancement and a large soft tissue component. Again, in this example, we can see the tumor having low signal intensity on T1 weighted images and low signal intensity on T2 weighted images indicating areas of mineralized bone. Regarding nuclear medicine, bone scan will show increased uptake, so it's used for staging and detection of skip lesions and metastasis. PET-CT scan is useful in evaluating a tumor recurrence, and it's helpful in imaging patients with prosthesis. For example, in this PET scan, we can see increased uptake in the left lower femur with no signs of skip lesions. Another example, in this case, with a metallic prosthesis, this will be very difficult to be evaluated in CT or in MRI. While in PET-CT scan, we can easily see the increased uptake in the area with multiple foci suggesting either residual or recurrent disease. So what's the differential diagnosis of osteosarcoma? Well, the list here includes Ewing sarcoma, osteomyelitis, chondrosarcoma, lymphoma, aneurysmal bone cyst, and myositis ossificans. Ewing sarcoma usually involves the diaphysis of long bones and almost always have a large soft tissue mass. Like in this example, we can see that the abnormality involves the diaphysis of the femur and there is a large enhancing soft tissue mass. Another example here, we can see the abnormality involving the diaphysis of the radius and there is a large enhancing soft tissue mass. Osteomyelitis does not show new bone formation and usually have sequestrum. Like in this example, we can see the bone cortex is thickened but without new bone formation, and a sequestrum is seen in the medullary cavity, suggesting osteomyelitis. Another example here, we see periosteal reaction is present but no distinct new bone formation, and sequestrum is seen in the medullary cavity, suggesting osteomyelitis. Chondrosarcoma is characterized by ring and arc calcifications with thickened cortex and endosteal scalloping. As in this example, we see ring and arc calcifications with endosteal scalloping typical of chondrosarcoma. Another example here showing clearly ring and arc calcifications with cortical thickening and endosteal scalloping clearly seen on the X-ray and on MRI and appear as a low signal intensity suggesting chondrosarcoma. Lymphoma is another differential diagnosis. Usually it appears as moth-eaten lytic bone destruction with no periosteal new bone formation. As in this example, we can see the moth-eaten lytic bone destruction in the X-ray with no periosteal new bone formation, while MRI shows significant and much more apparent involvement of the medullary cavity of the femur. Another example showing the marked moth-eaten lytic bone destruction in this X-ray with no significant new bone formation, suggesting lymphoma. Aneurysmal bone cyst can look similar to telangiectatic osteosarcoma as a purely lytic lesion with no periosteal reaction. As in this X-ray of aneurysmal bone cyst, which looks similar to telangiectatic osteosarcoma as lytic lesion with no periosteal reaction. However, the aneurysmal bone cyst is much more common than telangiectatic osteosarcoma. Another example of aneurysmal bone cyst which can be confused with telangiectatic osteosarcoma as lytic lesion with no periosteal reaction. This MRI image shows typical pattern of fluid level of an intraosseous lesion consistent with an aneurysmal bone cyst. Finally, myositis ossificans is characterized by new bone formation at the periphery and zonal phenomena, with cleft between the osseous mass and the bone cortex. While in surface osteosarcoma, there will be central new bone formation. Like in this case of myositis ossificans, we can see the new bone formation in the periphery and typical cleft between the osseous mass and the bone cortex. Another example of myositis ossificans showing a new bone formation in the periphery and the zonal phenomena. While in osteosarcoma, the new bone formation will be central in location. Another example of myositis ossificans with peripheral new bone formation and the cleft between the osseous mass and the cortex. Well, this was all for today's episode. Don't forget to subscribe, like, share, and tell your friends about us. If you have any comments, write them in the comment section. See you next Friday at 5 p.m. This is Dr. Ahmed Abdul Wahab, and this is Highlights in Radiology Season 2. Bye.